Now we are live, so hello to everybody. We are here again with you with all our passion for rhinology. I am very honored, I'm very grateful with the great Professor Reda Kamel. He will be giving our first webinar, and this is a topic that I really like. It's endoscopic management of JNA. Professor Reda Kamel, this for me is one of the great rhinologists that they are still practicing, and even more, he's like one of the biggest professor, but because he's so didactic and it's really easy to learn with him. So, Professor Kamel, thank you for being today with us, for giving us your precious hours. And I'm very grateful with you, and thank you very much. It's all yours.
Thank you, Cristo, very much for this nice introduction. And I would like to present to you my experience with the management of juvenile nasopharyngeal angiofibroma, the JNA. Thank you indeed for invitation. I have been many times to Barcelona. Unfortunately, this year, because of the COVID pandemic, we failed to meet together. And looking forward in the future to come again and again. Barcelona is my second country, because every year I come either once or twice a year. So thank you indeed for my invitation. Thank you.
You're welcome. Now I will share your screen.
I'm sharing my screen now.
Now, yes. Now you are in full presentation mode. Yes.
Okay. So now we can proceed. In fact, I just before want to present to you our very old work regarding the endoscopic sinus surgery. In fact, the old Egyptians were the first to utilize the nose to reach the brain, and they used the nose to reach the brain to mummify the body and remove the brain, and they used a lot of tools to do that for mummification. And in fact, they have a lot of tools, as you can see here. You can see the sickle knife, you can see the maxillary seeker, you can see the frontal seeker, you can see the Black's forceps, and so on. In fact, the interest of Egyptians to reach the skull base goes to 7,000 years ago. Again, we are lucky because we published our first publication regarding the endoscopic surgery of JNA, and this publication, the first publication all over the world, to suggest a transnasal endoscopic approach to reach the nasopharyngeal angiofibroma and to handle it. And we can notice that it was only one case we began with. It was very limited to the posterior nasal fossa, nasopharynx, and pterygopalatine fossa. And at the end, we stated that this approach is suitable for the management of angiofibroma, very selected cases. And at that time, the option or the assumption of taking care of an angiofibroma via the nasal cavity endoscopic without a need for lateral rhinotomy or midfacial degloving was a big change of the maneuvers of handling angiofibroma. Before we go to angiofibroma, one should understand the anatomy of this area. The anatomy begins by, here we have here the palatine bone, and we have the sphenoid process, and we have the ethmoid process, and the sphenopalatine notch. And then we have here the sphenoid bone, the three parts, the sphenoid process, the ethmoid process, and the sphenoid bone constitute the sphenopalatine foramen. The sphenopalatine foramen is supposed to be the site of origin of the JNA. And here we are. Again, the site of origin of the angiofibroma is the sphenopalatine foramen, or the area of the sphenopalatine foramen. And we understand at the area of the sphenopalatine foramen, we have the sphenopalatine artery, the main blood supply of the JNA. One should be aware of the blood supply of the JNA, because the most important part of the story is to take care of angiofibroma. It's a highly vascular lesion. And accordingly, we understand that the sphenopalatine foramen divided into the lateral nasal and the posterior septal branches. And usually they supply the main supply of the JNA. To understand the anatomy, one should begin by the sphenopalatine foramen, then the pterygopalatine fossa, then the pterygomaxillary fissure, and then the infratemporal fossa. This is in the coronal cut. And then the superior orbital fissure. One should understand how the superior orbital fissure is too near to the pterygopalatine fossa. And then the optic nerve. The optic nerve is near to the growth of this JNA. And then the axial cut. The axial cut, again, we have here the sphenopalatine foramen, the pterygopalatine fossa, pterygomaxillary fissure, and then the infratemporal fossa. Anatomy, anatomy, and the anatomy again. And then whenever we are going to take care of an angiofibroma, one should be aware of the foramen rotundum and the V2, of the Vidian canal or the pterygoid canal and the Vidian nerve, and then the palatovaginal canal and the pharyngeal artery. Pharyngeal artery is one of the main supply of the JNA. So one should be aware of this markedly. Then again, the pterygopalatine fossa and the infratemporal fossa. And again, this is the foramen rotundum and the V2, and then the pterygoid canal and the Vidian nerve. Anatomy, anatomy, and anatomy again. And then the superior orbital fissure. Now we can proceed to the anatomy. Now I just want to show you, this is one of the dry skull. The dry skull left side. This is a mega antrostomy showing the posterior wall of the maxillary sinus, the ethmoid bone and the sphenoid bone. And then we can proceed. Going too near to this area, now we can expose the posterior wall of the maxillary sinus, which is nothing but the upper 2/3. Here we are. The upper 2/3 are the anterior wall of the pterygopalatine fossa. And now we have here, this is the palatine bone, the ethmoid process, and the sphenoid process, and the sphenopalatine foramen. When we go nearer to this, here we are. This is the same view. When we go nearer to this now, this is the ethmoid and the sphenoid processes of the perpendicular plate of the palatine bone. And here we are. Here we have the sphenoid bone. We can see here the sphenopalatine foramen, through which we can identify this red rod. It resembles as if it were this sphenopalatine artery. And far behind, this is the mouth or the opening of the pterygoid canal, through which the Vidian nerve exits. And then when we go using the angle telescope to see inside the pterygopalatine fossa, we can visualize here not only the Vidian but also lateral and superior. We have here the foramen rotundum. The foramen rotundum, through which this green rod looks as if it were or resembles the V2. So now we understand the relation between the Vidian canal and lateral and superior. We have here the foramen rotundum and the V2. And then whenever we have more and more tilt, now we can identify not only the Vidian but also the palatovaginal, and lateral and superior we have here the foramen rotundum. And then if we had more and more tilt, now we can see not only the pterygoid canal but also the foramen rotundum, not only the foramen rotundum but also the pterygomaxillary fissure, not only the pterygomaxillary fissure but the maxillary artery going into the pterygopalatine fossa via the pterygomaxillary fissure. So it's anatomy, anatomy, and anatomy again. And then after removal of the anterior wall of the fossa, which is nothing but the upper 2/3 of the posterior wall of the maxillary sinus, we can identify the V2, the Vidian, and the pterygomaxillary fissure, and the infratemporal fossa. So it's anatomy. Understanding this anatomy and this area will pave the way to go into the management of the JNA. Now we cannot see it. This is again the Grant's Atlas, very old atlas, and magnification, we can understand, here we are, this is the sphenopalatine foramen, and then here we are, this is, here we have the pterygoid, and then we have here lateral and superior, this is the foramen rotundum, and then we have here the palatovaginal canal near to the pterygoid, and then we have here the superior orbital fissure. So anatomy again, and then lastly we have here is the pterygomaxillary fissure and infratemporal. The artery, the maxillary artery enters into the pterygomaxillary fossa and then exits as the sphenopalatine artery, dividing into the lateral nasal and the posterior septal. We understand that posterior septal is a very important supply to the nasoseptal flap, but in an angiofibroma, it is the main supply of the JNA. So now again, the V2 coming via the foramen rotundum. Then we again to our the translator endoscopic surgery of juvenile angiofibroma. We are lucky because the first publication in the world regarding the possibility of utilizing the transnasal approach to take care of JNA was from our university, Cairo University, and we were the authors of this publication. We began by very small angiofibroma, very small angiofibroma, limited to the nasal cavity, sphenoid, and the pterygopalatine fossa. And at that time, we could remove it. You see, very small and concise. And at that time, we began to state it is for very limited angiofibroma. But we understand that this is the sphenopalatine foramen. And then the angiofibroma grows from the sphenopalatine foramen to the nasal cavity, grows to the nasal septum, grows to the sphenoid sinus. This is the medial encroachment of the angiofibroma at the expense of the nasal cavity and nasopharynx and sphenoid sinus. And then it may extend to the cranial cavity via the sphenoid. But in most cases, it grows into the pterygopalatine fossa, and it may go again into the infratemporal fossa. But sometimes it grows into the orbit via the inferior orbital fissure into the orbital apex, and then via the superior orbital fissure, it may go into the cranial cavity, but in such a case, into the cranial cavity lateral to the internal carotid artery. In such a case, it's medial to the internal carotid artery. And I'm going to show you the difference of this. So now we are facing a very highly vascular lesion, locally invasive and aggressive malformation, high incidence of persistence and or recurrence. Accordingly, the only management of JNA is radical and complete surgical excision. There is no medication. Radiotherapy is not an option at all, except again. So it's a radical excision is the only option for taking care of angiofibroma. Classification. To plan surgery, we have to go to the classification. May depend on the size, on the location, the extent of the angiofibroma, the routes of spread, and the expansion. And we have a lot of classification, but the aim of classification is basically to plan surgery, to expect difficulty of surgery, to anticipate residual or recurrent disease, and to be able to compare results of different institutes and different centers. And you have a lot. Before endoscopy, the main classifications were like this. But we have to state, you see, basically the nasopharynx and nasal cavity were considered as the first stage, and then the sphenoid sinus, maxillary, and or pterygopalatine extension into the pterygopalatine fossa was considered as a relatively more advanced stage, and then extension into the orbit and or cheek or infratemporal, this is another stage, and then extension into the cranial cavity was considered. And accordingly, we have a lot, the Andrew, the Fish, the Session, Radowisky, and Chandler. All these classifications depended on the size of the disease and the extension of the tumor. The pre-endoscopic era, open surgery was the only option. The transpalatal approach was a usual happening. The transfacial approach, lateral rhinotomy, and so on and the mid-facial degloving. The temporal fossa approach was suggested, and then the transcranial approach was suggested. Can you imagine that once upon a time, the state of the art was only external approaches to JNA? Then the vascular malformation, this muscular malformation, the mid-facial degloving approach began to be suggested. Why? To avoid the external approach. But we understand that JNA being a vascular malformation, the bleeding and death is a possibility. Recurrence and residual is a big possibility. But one should understand where to stop. Again, our publication. Here we are. The progress began regarding the tools, the endoscopes, the cameras, the drills, the shavers, and so on, the surgical instruments themselves, and then the accumulated experience. Accordingly, now we can state it that most of angiofibroma are managed via a transnasal approach, and accordingly, many classifications began to arise after the transnasal endoscopic era, including the Anarchi, Carillo, Snyderman, and Janik Karam. All these classifications aimed to put the rules when to utilize the endoscope and to stage the difficulty of the operation and to expect the expectation of residual disease and or recurrence. Here are the methane. Here are regarding the nose and nasopharynx sphenoid. This is relative and minimal involvement of the pterygopalatine fossa. This stage 1, and then including the maxillary anterior cranial fossa and on. So the classification was based basically on difficulty of operation and expectation of the recurrence. And here we are. We understand now it's very limited. The intracranial lateral to the internal carotid artery is the only limitation to endoscopic sinus surgery. Now we begin our experience. Most of our cases, usually we embolize. Why to embolize? To render the operation relatively safe. Because if you take care of an angiofibroma not embolized, definitely you may face a lot of problems. If you achieve good embolization, the bulky and the vascular tumor will change into a relatively, I don't want to say a vascular, but this vascular tumor. So the preoperative embolization is common happening in our everyday work. Now I just want to show you from the start one of the cases. Here we are. This is a case of the right nasal cavity, and we can appreciate how the V2, the foramen rotundum, and the pterygoid canal are muffled by the disease, and how the extension of the tumor pushing the internal carotid artery. Here we are, and the MRI. Here we are. This is the paper. Here we are. You see this, the black dots. The black dots showing the paper dots means that this is a vascular tumor pushing the internal carotid artery, and accordingly, in such a situation, here we are again, a vascular tumor and pushing the internal carotid artery. But the push of the internal carotid artery is from medial, and accordingly, in such a case, I'm going to show you what happened in such a case. I'm going to show you this case from the start, showing this is the angiofibroma, and we began by taking care of the middle termit to show what we are going to do. Here we are. We removed the onset process, and then after removal of the onset process, we began to take care of the ethmoid above the tumor. We want to offer an ample space, and then we could achieve the ethmoidectomy, and then we could reach the sphenoid sinus, and then we began to dissect it off the septum. After that, we began to proceed regarding pushing the tumor inferiorly, and then we began to take care of the maxillary sinus to perform a relatively wide middle meter antrostomy and stop at the nasolacrimal duct, and then we began again and again to widen the opening above the tumor, and then we began to release the tumor at the sphenopalatine foramen, and here we are. we are trying to, after removal of the anterior lip of the foramen, we began to pull the tumor from within. Here we are, this is removal of the bone, and then to dissect the tumor from lateral to medial, and then to cauterize the site of the sphenopalatine foramen, and then the optic nerve began to appear, and we began to, here we are again, to remove more bone to offer an ample of space to deliver the tumor. This is the anterior lip of the foramen, and then we want to offer a very capacious cavity to be able to proceed. And now you are delivering the tumor, the fingers of the tumor, the optic nerve, the carotid artery. I'm going to show you this after even removal, and then we begin to dissect the tumor from the optic nerve and the carotid artery, Here we are, and then we begin to push the tumor posterior and inferior, delivering the sphenoid part, the pterygopalatine, the infratemporal, and then here we are. This is pushing the tumor again and again to be able to get all the fingers without missing any finger. Now we began to understand that the tumor is adherent to the clivus, the upper clivus, and then we began to deliver and to dissect the tumor finger into the sphenoid sinus and the part of the tumor pushing the carotid artery. You can notice how vascular the tumor is despite of the preoperative embolization. Now we began to try to deliver the tumor via the nasal cavity. We realized that it's too big to be delivered via the nasal cavity, and we began to push it to the oral cavity, and then we began to deliver it via the oral cavity. How big the tumor is, and now, and only now, this is the optic nerve, the OCR, the carotid artery, this is the V2, the median canal, and then we apply, this is the tumor, how big the tumor is, and again, now we can understand that we removed the tumor in toto. Here we are, this is the tumor. Now we can put the philosophy. The philosophy is the center is the sphenopalatine foramen, extending either medially or laterally. Here we are, the extension into the pterygopalatine fossa. One should be aware of the removal of the upper 2/3 of the posterior wall of the maxillary sinus, which is nothing but the anterior wall of the pterygopalatine fossa. After removal of this part, one will be able to remove the anterior lip of the foramen. Removal of the anterior lip of the foramen is very important to release the dumbbell shape. And here we are. Now, this is one of the cases where we began. You see here, this is the dumbbell shape, and accordingly, one should release the tumor down here. And accordingly, you see here, this is the dumbbell shape, and accordingly, I just want to show you here one of the cases to show you. This is the right side, the nasal part of the tumor, nasopharyngeal part of the tumor, and this is the pterygopalatine fossa and the infratemporal fossa. And this is the anterior lip. We removed only the upper 2/3 of the posterior wall, which is nothing but the anterior wall of the pterygopalatine fossa. And now we began to utilize the burr. Why? We want to thin this lip, and then here we are, the anterior lip or edge of the sphenopalatine foramen. Here we are, and then we began to use the Carotid, and we release. After releasing this neck or the dumbbell shape of the tumor, you will be able to remove it. I just want to show you. This is a case where we began. Here we are. You see here, this is the medial part of the tumor, the lateral part of the tumor. And then we began, here we are, to utilize the, here we are, this is the Carotid. The Carotid utilized to remove this anterior lip of the, using this part of the, where we are, we can proceed some more. Here we are, we can use the burr aiming to thin this anterior lip, and then we can use, here we are, this is the maxillary seeker to show you the anterior lip, and then after that we can use the Carotid. to remove it. Here we are. This is the case. Another case. Here we are. This is the pterygopalatine fossa extension. Very clear. You see the pterygopalatine fossa extension and the neck. You have to release this neck. Otherwise, here we are. This is the same case. I don't want to. This is after removal. You see, we have a very big cavity and no residual and or recurrence. The Vidian canal is very important. Here we are. The Vidian canal is very important. The Vidian canal, here the Vidian canal intact, the Vidian canal muffled, the Vidian canal muffled again. Here we are. And here we are. This is the Vidian canal. And accordingly, you see the Vidian canal part of the tumor. And here we are on the right side, the Vidian canal and the palatovaginal canal. Here we are. The Vidian canal affected and the palatovaginal canal insulted by the tumor. So one should be aware of these areas, otherwise you may miss part of the tumor. Now the tumor may grow not only medially but also laterally into the pterygopalatine fossa and then into the infratemporal fossa. Growing into the infratemporal fossa, as you cannot see the fingers, the nasal finger, the maxillary finger, the pterygopalatine and infratemporal, and then the parapharyngeal space, and this is the nasopharyngeal part. All these 5 fingers should be removed. If you missed one of this, this is unfortunately the path or the way for residual and recurrence. Then, whenever we have an infratemporal fossa, we do not remove only the upper 2/3 of the posterior wall of the maxillary sinus, but also we remove the lateral wall. Here we are. Removal of the lateral wall will give you a space to go into this. Here we are. One of the cases where we have, you see the bulge in the cheek. You see the bulge in the cheek, the bulge in the cheek, the bulge in the cheek. And here we are. In such a case, we have the big tumor into the infratemporal. Via this neck, we have to release this neck. Otherwise, we will not be able. And I just want to show you this case where we have here, you see, this is the removal of the anterior wall of the fossa. Removal of the anterior wall of the fossa will give you the chance to release and to remove and to deliver the infratemporal fossa part into the nasal cavity and to deliver the tumor. You see, very thin posterior wall of the maxillary sinus, which is nothing but the anterior wall of the fossa. After removal of this, one will be able to release the tumor and to deliver it into the nasal cavity. There we are. You see here, this is the lateral part, the medial part, and then we can proceed. And this is the neck, and accordingly, we began to take care of such a big tumor, and then we began to try to deliver it via the nasal cavity, but we realized that it's important or impossible to deliver it via the nasal cavity, and accordingly we began to try to deliver it via the oral cavity, and here we are. This is the tumor removed via the, here we are, the oral cavity as well. Now the other possibility is extension into the orbit. Extension into the orbit usually via the inferior orbital fissure. Extension into the orbit, you see here the orbit via the pterygopalatine fossa and then the inferior orbital fissure. And here we are, one of the cases where we had to deliver the tumor. What we did orbital decompression and orbital apex decompression, and we began to deliver the finger of the tumor via the nasal cavity from the orbital apex, as you cannot see here, from the orbital apex, delivering. We want to deliver it in toto, the whole finger, not only part. If we left part of the tumor, this is the residual disease and recurrence. And we can notice here, we are pulling smartly, angiofibroma. This is the way we can proceed and we can get the tumor out from the story. Then the last situation is the intracranial extension. The intracranial extension may be via the root of the sphenoid or via the root of the orbit. And here we are. The first possibility is from the sphenoid, medial to the carotid. easy. And then the other part is orbit to the superior orbital fissure, and this is relatively difficult, lateral. And then pterygopalatine, inferior to the carotid, and may be easy. But one of the worst situation is regarding the via the foramen ovale and the mandibular branch. And just one of the case, here we are, this is the sphenoid extension, medial to the carotid, easy. Here we are, sphenoid, here we are, the carotid is lateral, easy. But whenever we have a case like this, we see here, this is the extension via the orbital apex into the cavernous sinus and the medial cranial fossa, lateral to the carotid, difficult. And then one of the most difficult situation is the extension of the tumor via the foramen ovale into the medial cranial fossa, and this is a big problem. Whenever you are going to work at this area, one should be aware of the vasculature of this area and the nerves. And accordingly, I just want to show you the anatomy of this area, which is very important. Here we are, this is the anatomy where we have to be able to understand this is the carotid artery, anatomy, and the carotid artery, tilting the carotid artery will show you, here we are, tilting the carotid artery, will show you the third nerve, the fourth nerve, the sixth nerve, the V1, and then the V2. So it's the anatomy and anatomy again. If you are going to work at that area, one should be aware of the anatomy, the optic nerve. Here we are, this is the optic nerve left, and then this is the optic chiasm, optic radiation, and this is the A1 and ACOM and A2, and here we are, this is the olfactory, and then this is the olfactory nerve. The area, their anatomy should be understood properly, and then you have to be aware of the division of the anterior carotid artery into the anterior cerebral and the middle cerebral, and then the siphon of this is the middle cerebral, anterior cerebral, and then this is the siphon of the carotid artery, and that's very interesting. This is the posterior communicating and basilar and posterior cerebral and third nerve and superior cerebellar artery. The anatomy again. In such a case, we have to remove again the anterior wall of the fossa, anterior lip of the foramen, and then we can proceed to remove the whole tumor. One of the cases, here we are, where we have here an extension intracranially and into the cavernous sinus. And in such a case, we succeeded to remove the whole stuff, including the sphenoid sinus, the nasopharyngeal part, sphenopalatine part, pterygopalatine part, infratemporal, orbit, and intracranial part of the story. So we can come now to the conclusion because of the time allowance, and here we are. This is the JNA originates from the sphenopalatine foramen. JNA follows very strict paths to distant location. You have to understand and study the path of extension of angiofibroma. It infiltrates and compresses bones, and proper understanding of the routes of spread and pattern of growth of angiofibroma helps achieve complete excision and avoid residual and or recurrence in the future. Before I close, I just want to invite you all to come and visit Egypt next year, Rhino Egypt 27th, March 1st to 6th. You can come to visit Egypt for the conference, and at the same time, the conference is a very big conference, big attendance, and at the same time, big faculty. You can visit the pyramid, and we are lucky. We have a lot of our colleagues, and this is our team, and this is our journal. And I would like to advise you to submit your article to the Pan Arab Journal of 10 years old, and it's online, open access, and peer review. And advise you again to have this copy of this anatomy of the lateral nasal wall. You can download it free of charge from my website. And at the end of the story, I would like to say thank you and ready for the questions. Thank you, Christian, very much, and looking forward for any question.
Thank you, Reda. It was an amazing lecture. As always, anatomy is the key. Anatomy again. Amazing. There are some questions. One question from Joseph Saleh is, do you do medial maxillectomy as routine for your approaches for lateral
regarding the
extension?
medial maxillectomy, in fact, we tailor our surgery according to the extent of the disease. Usually, we perform a wide medial meta-arthrostomy, and in most of the cases, we perform a very, very big medial meta-arthrostomy, but in most of the cases, we preserve the integrity of the nasolacrimal duct, especially if we have a relatively far lateral extension into the infratemporal fossa. So usually, we tailor our surgery according to the extent of the disease and to the root of the extension of the disease as well.
Okay. I will ask you some questions just to
Please.
put you in trouble. Maybe you don't have because of your expertise, but if you have a tiny remnant in cavernous sinus or, I don't know, in infratemporal fossa, what is your algorithm to manage this? What do you do?
Whenever the tumor is located in what?
No, if you have if you did the surgery and you make an MRI, 6-month MRI, and you see a remnant of JNA in cavernous sinus or at the level of B2, I don't know.
By chance, not prepared to.
Sorry.
The question again, because I realized
what
that
do you do? What do you
face a JNA by chance or
occurrence or persistence of disease?
It seems that the connection is not very clear. So the question again, please, Christoph.
Sorry. How do you manage with persistence of disease? If you have or recurrence of disease of JNA.
The origin or which part of the JNA?
Yeah, whatever. If you live, yes. If you have a recurrence.
A recurrent case.
Yeah, recurrent. Yes.
In a recurrent case, it's the same story. Christopher. So in a recurrent case, the most important part of the story is to understand the fingers of the angiofibroma. Where are the fingers? Where are they located? And how did they grow up there? Is it intracranial, intraorbital, pterygopalatine, infratemporal, retropterygoid, parapharyngeal, or whatsoever? So the most important part of the story is to be able to understand the fingers of the angiofibroma and to remove all these fingers. If I failed or you failed or anybody failed to remove one of these fingers, he or she should revise matters at the end of the surgery and even after surgery to perform the post-operative MRI with contrast to understand the feasibility or the possibility of any residual disease.
Great. There's another question just to stress out this thing.
Yes, please.
So you go for a recurrent disease, you go always for surgery. You never advise radiotherapy?
Never, because you see, never, because you see, surgery is the best option. Surgery, in most of the cases, is successful. Surgery hardly ever leaves a residual in good hands. And I understand, and you understand that radiotherapy in a teenager is very, very crucial because it may induce malignancy. So we do not resort at all to radiotherapy, except in very, very limited indication whenever we have a relatively dangerous intracranial part which is still growing. Sometimes there is a small intracranial part left, and you follow that part and no growth. You leave it in peace. Because if you use radiotherapy in a teenager, the possibility of a thyroid carcinoma and a lot of any malignancy is so we don't resort to radiotherapy as a first line of management at all. And in most of we are lucky because any teenager with bleeding male patient is angiofibroma until proved otherwise. So we are lucky because with the use of the endoscope nowadays, any reddish mass behind the middle turbid is a very good direction. This is an angiofibroma. We have to ask for CT, MRI, angiography, embolization, and so on.
Awesome. Perfect, mate. I do the same. I'm completely agree with you. There's another question regarding the Vidian canal and the Vidian nerve. I think maybe it's do you drill always Vidian canal or?
The Vidian canal is very important. It's very important. That's true, because you see, in many cases beforehand, when we were unaware of the importance of the Vidian canal, it seemed that the site of residual disease was in the Vidian canal. So it seemed that you have to make sure that the Vidian canal should be visited whenever it is involved by the disease. That's why the CT study, the bony cut, is very crucial. You have to understand the anatomy of the direction of the two Vidian canals, and the directions of the palatovaginal canals, because it's not only the Vidian but also the palatovaginal. Palatovaginal, you have to visualize the opening of the foramen of the Vidian, or the opening of the Vidian canal and the palatovaginal canal, and you can cauterize them, you can drill them, but be careful, don't go far posterior, because this is the direction into the internal carotid. And in most of the cases, the canal is already taken care of and clarified.
Exactly. Yes. Another question regarding pre-op embolization is: you always do embolization in all your cases?
The question again, please. Sorry, because the connection.
Yeah. Pre-operative. Yes, pre-operative embolization. Do you do always embolization in all your cases?
In all my cases, in fact, I resorted to pre-operative embolization. We are lucky because at Cairo University, we have very good interactive radiologists who they are able to perform safe and very selective embolization without any complication. And usually you perform this type of embolization 1 day before surgery, maximum 2 days, but in most of the cases it's 24 hours before surgery maximum, to make sure that the tumor is embolized, and at the same time no collaterals. And we are lucky because without embolization you can do it, but you are unsafe, and if bleeding is heroic, it is like a heart. You open a heart, so
exactly
feasible to perform embolization preoperatively. It will be very wise.
Great. 2 more questions. One is: did you face a case needs orbital mobilization, and how you did it?
What was that again?
Can you read it? It's: did you face a case that needs orbital mobilization, and how you did it?
It is very interesting question, the orbital mobilization. Yeah. In fact, we are lucky and unlucky. Regarding angiofibroma, when the angiofibroma visits the orbit, it does not visit the orbit by pushing the orbit laterally. In most of the cases, it invades the orbit via the inferior orbital fissure into the orbital apex. So in such a case, if you have a finger into the orbital apex, and that finger may extend again into the medial cranial fossa via the superior orbital fissure, as I showed you, what we usually do, we do orbital decompression for the posterior part only, not the anterior part. And we do orbital apex decompression, not only from medially, but also from inferiorly. Inferior and medial gives us a chance to deliver and to pull the finger of the angiofibroma that invades the orbit and gets into the cranial cavity, if it is the case. So this is a very interesting and important question, and usually one should be aware of the extension, and in this situation he or she should have very good capability of endoscopic sinus surgery to be able to remove the angiofibroma completely without insulting the optic nerve or the ophthalmic artery or whatsoever into the cavernous sinus.
Exactly. And what I always say our fellows that this kind of tumors is the tumors where you bring your operation field towards you. You don't have to go to the tumor. You pull the tumor to the operation field. So they are, in most of cases, you don't need like this big resection to deliver the tumor. If you follow and you pull the tumor, it will come to you and you can take it out.
That's true. That's true. Yeah. I agree.
Yes. Two last question, Reda, and we will leave you.
The coming one is paid. The last one, this is the coming ones are paid.
Yeah. Okay. Perfect. So, what is the role of coblation in JNA?
This is very, thank you very much for this question. This is free as well, no problem. Why? Because coblation, some surgeons state that coblation is effective in angiofibroma. In fact, I tried coblation in angiofibroma, but I realized that it is a time consuming, and it does not decrease the size of the angiofibroma dramatically. And the most important part of the angiofibroma is not, because the idea of coblation is to invade or to visit the tumor itself. But our idea, every endoscopist does not invade the tumor at all. We work around the tumor. We deliver the tumor. We pull the tumor. We do not shrink the tumor, because you see, we may use the bipolar, but bipolar is very dangerous because it changes the texture and the color of the tumor, and it may cut the tumor and leave a part. So regarding coblation, in my own experience, I did not find that it is helpful at all. Time consuming and very slow, and I invade the tumor itself. I do not want to invade the tumor. I want to go around the tumor and deliver it in toto if it is feasible.
Perfect. Amazing. And the last question is, this is interesting. How do you manage venous bleeding from the pterygoid process or the pterygoid plexus? It's really annoying to.
Yes. In fact, bleeding from the pterygoid plexus is not a big problem. But you see, maybe the difficult question, how to manage bleeding during angiofibroma. I would like to tell you something and the story regarding the bleeding. Bleeding may be from the sphenopalatine artery and the pterygoid plexus veins, the sphenopalatine artery. We can reach it. You can cauterize it. Bleeding from the upper clivus, the lower clivus, the tumor invades the bone. It looks for blood, and it invades, and you can dissect the tumor off. Unfortunately, dissection of the tumor, if it is invading the clivus, a big part of the clivus, the ooze, you cannot stop the bleeding. That's why in the case I showed you, we may use the gel foam and stop it, surgery cell and stop it, no problem. But sometimes the ooze is venous and for a long, big amount, to the extent that one case during surgery, we finished surgery and everything was perfect, and we began to take photo of the removed big tumor, and we were very happy because the video was perfect and everything was perfect. But the last part was tedious because we dissected the tumor and we spent a lot of time, and then suddenly the anesthetist said, "Oh, we don't have a pulse. The patient is arrested," and hop, within a fraction of seconds, 15 doctors came into the room, and me myself, I left the room to the WC. Definitely, I failed to stay in the room, and the 15 physicians from anesthesia team, 15, they are well trained. They came and they did tracheostomy and did intracardiac adrenaline and bicarbonate and resuscitation. Unfortunately, I visited the patient in the evening he was very, very happy and walking and so on. I was so the bleeding sometimes is a very bad experience.
Exactly.
It happened to me once, but I was very, very lucky because of the resuscitation team.
Even more that they are always young patients, so it's never. It's always
that's true. He was very young, and according you could withstand easily the arrest for few seconds. I don't want to say minutes.
Exactly. Okay, Reda, thank you very much. Really, I hope we can see each other. I hope in Cairo. I will try to go. If not here in Barcelona, I would like to invite everybody to our next session. Our dear fellow, the Professor Dr. Laura van Gerwen, will talk to us about how to approach complication of acute rhinosinusitis in children next Tuesday. So you're all welcome to participate and join us in Barcelona Rhinology School. Reda, thank you very much. Amazing lecture as always. I've always liked to talk to you because of your passion about this topic. It's always a boost for me.
Looking forward to see you back soon in Cairo next March and in Barcelona next April.
Exactly.
And my best greetings to all my colleagues in Barcelona, my second country. Thank you very much.
I will transmit. See you. Bye. Goodbye, everybody. Thank you for joining us. Bye.
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 Bye. Bye.